So first we'll start with the case presentation. So the case is 6-year-old female, non-diabetic, who was on insulin and hypertensive, came to the ER with chief complaints of multiple episodes of vomiting, abdominal pain, and altered sensorium since last night. So on examination, she was drowsy, lethargic, and disoriented, and her vitals were, she was in sinus tachycardia, her heart rate was 139, BP was 100/70, she was tachypneic with respiratory rate of 35 per minute, and her room air saturation was 92. Coming to the investigations, her blood glucose was 525 and HB 16 gram per deciliter, and total leukocyte count was 22,000 and platelets were 3.2 lakhs. Serum creatinine was 1.7, sodium was 130, potassium was 3.8, and in complete urine examination, the urine ketones were positive and urine contained plenty of pus cells. When an ABG was done, she was in anaerobic metabolic acidosis with lactic acidosis. So before discussing the case presentation, we will discuss the cause of hyperglycemia in this patient. Not only in this patient, usually what are the triggering factors or what are the causes for hyperglycemia. 25% of the patients, they won't have any precipitating causes. Most of them are almost like 10 to 20% will be with acute illness, and some of them will be omitting the insulin or non-adherent to the treatment, and some of them will be having infection, whether it is urosepsis or any other infection in the body. And other conditions being MI, stroke, pancreatitis, trauma, and other stressful events like pregnancy, surgery, hyperthyroidism, pulmonary embolism, even steroid use, where usually we are seeing it in COVID situation, more steroid usage is done, and it may be new onset diabetes also. So usually the triggering factors are as follows. So then coming to the discussion of hyperglycemia, what is the definition of hyperglycemia? If the blood sugar is more than 180 milligram per deciliter, it is called as hyperglycemia. So what is stress hyperglycemia and what are the causes of the stress hyperglycemia? So stress hyperglycemia in critical care illness is usually caused due to the excessive release of the counter-regulating hormones like glucagon, steroids like glucocorticoids, growth hormone, catecholamines. And these counter-regulating hormones alter the carbohydrate metabolism by increasing the peripheral glucose demands, hepatic glucose output, and it increases the insulin resistance, causing relative insulin deficiency as well. And even the inflammatory cytokines which are released during the stress like IL-1, IL-6, and tumor necrosing factor alpha also contribute to the stress hyperglycemia. And in as such, some patients with diabetes mellitus, obesity, cirrhosis in the background, they have impaired glycogen storage. And in pancreatic patients and severe illness patients, they have insulin deficiency. And in advancing age patient and hypokalemia conditions, there is inadequate insulin secretion. All these conditions contribute to stress hyperglycemia. So next, coming to the next slide. So what are the adverse effects of the hyperglycemia? We are talking so much about hyperglycemia. What does it cause actually? So what are the bad effects of the hyperglycemia? So whenever there is glucose load in the blood, it causes osmotic diuresis, leading to water loss and as well as electrolyte loss like potassium, magnesium, phosphate in the urine. And this causes dehydration as well as electrolyte disturbances. Because of this osmotic diuresis, there is hypovolemia and perfusion is less, causing lactate increase, so causing lactate acidosis and as well as ketosis accumulation in the body. And there will be muscle wasting, and because of the muscle wasting, it increases the risk of critical illness, neuropathy or myopathy. If the patient is on ventilator, it causes delayed weaning. And it also causes delayed wound healing and impaired wound strength, especially in the surgical patients. So it also increases the risk of infections. It impairs the fibrinolysis, platelet function, causing hypercoagulability and increases the risk of thrombotic events. It also increases the generation of reactive oxygen species, so causing hypoxia at the cellular level, at mitochondrial level, increasing the risk of organ failure, especially renal failure, and causing death in the critically ill patients. It also increases the levels of free fatty acids. So what happens if the free fatty acid levels are increased? It increases the myocardial oxygen requirements, and it thus causes ischemia. Because of ischemia, it decreases the myocardial contractility And because of the decreased myocardial contractility and other factors, it may also cause arrhythmias. So we can see in this slide, in this graph, that hyperglycemia is directly proportional to the mortality. It is generally associated with increase in mortality. So what are the beneficial effects of giving insulin and maintaining normal glucose in blood? So all factors which we have discussed, like adverse effects of the hyperglycemia, are counteracted. So it restores the dyslipidemia, that is by decreasing the triglycerides, by increasing the HDL cholesterol, and it will promote the anabolic actions. It increases the muscle protein synthesis. So there is no, I mean, whatever muscle wasting is there, we can inhibit that. And it also decreases the free fatty acids. And as well as the inflammatory cytokines like IL-1, IL-6, and tumor necrosis factor alpha, all these cytokines will be decreased. So adhesion molecules are also decreased and anti-inflammatory cytokines are increased. It also decreases the reactive oxidative stress, and it as well as it protects the mitochondria at the cellular level. It protects the endothelium by generating the nitric oxide and by decreasing the tumor necrosis factor alpha. So overall, these are the beneficial effects of the insulin and maintaining the blood glucose at normal level. So how should we monitor? So blood sugar monitoring can be done bedside, like a point of care with the glucometers, or the blood sample can be sent to the lab. It can be done continuously or it can be done intermittently. And it varies from sampling site. The sample can be a capillary blood or venous blood, venous plasma or venous whole blood, or arterial line. Sampling also can be taken. So what is the mechanism behind these devices? So what is the method of testing in point of care devices like glucometers? Here glucose oxidase enzyme is used. So this enzyme related reactions result in the production of gluconic acid and as well as hydrogen peroxide. And the hydrogen peroxide is detected by various methods in the various glucometers. In the central laboratory technique, hexokinase enzyme is used. So what does it do? Hexokinase enzyme phosphorylates D-glucose to form glucose 6-phosphate, which then is oxidized with concurrent reduction of NAD to NADH. So this reduction is detected in the lab level. So coming to the sampling side, how does it vary? Or the technique, how does it vary the glucose value? So in various studies, we observed these findings like mean capillary whole blood glucose measurements from various glucometers combinedly. Actually, the value was 3.2% higher when compared to the venous plasma glucose determined by the central laboratory method. And when we have used the venous whole blood with the glucometers, it was found to be superior when compared to the capillary whole blood of used. I mean, same device has been used for both venous as well as capillary whole blood, but venous whole blood was superior. And the difference was only 0.76 milligram per deciliter when glucometers were used for arterial whole blood and lab value was used for arterial whole blood. So whenever there is a hypotension, it results in the reduction of perfusion and glucose utilization also will be more. So that time we can't use the capillary sample for measuring the glucose. So it should not be done. Capillary test should not be done in specific situations. So what are the specific situations? Whenever the patient is in shock, whenever there is hypoxia, whenever the patient is dehydrated, extremes in hematocrit, whenever the patient is anemic or polycythemia is present, elevated bilirubin like jaundice, triglycerides. So whenever the patients are on drugs like acetaminophen, paracetamol, dopamine, salicylates, all these capillary tests should not be done. So what are the potential interferences when we use glucose meter or glucometer? So the factors are divided into environmental, physiologic, operational, and drugs. So what are the environmental factors? Whenever the strips are exposed to air, whenever there is an altitude change, whenever there is a change in humidity, change in temperature, all these environmental factors interfere with the glucometer readings. So what are the physiological factors? As I said, hematocrit values, postprandial state, hyperlipidemia, oxygenation, pH, all these alter the glucometer readings. So what are the operational factors? Hemolysis, whether the patient is on any anticoagulants, whether we are using any generic test strips. So what there is any contamination with amniotic fluid or arterial blood sample, volume of the sample, reusing of the strips. So if the patient is on maltose or vitamin C like ascorbic acid, mannitol, dopamine, all these factors interfere with the glucose meter readings. So what are the other factors that affect the accuracy? First, the user error. So if we take the sample inadequately or we have contaminated the sample, so usually there will be an error. So usually the best bleeders are thumb and ring finger. So coming to the test strips, as I said, environmental factors like exposure of strips to air, exposure to heat, humidity, all these affect the accuracy. So we have to minimize the exposure to air. We have to do proper storage of the test strips. We have to keep it in the original container and we have to recap immediately. And coming to the maintenance of the glucometer, whatever device we are using, if the meter is on low battery, so obviously it will cause inaccuracy. If there is any damage to the optic window of the meter, if the meter itself is dirty, all these cause inaccuracy. So we have to encourage the client for proper calibration also. Some of the glucometers are automatically calibrated. If they're not automatically calibrated, the person, whoever it is using, should be in a habit of calibrating meter with each new box or each new bottle of the strips. So finally, how to measure? So there are various types of lancets. There is a pen type of lancing devices. This is an AccuCheck multi-clicks. So each has 6 to 10 lancet strips inside that. So all these lancets are used for pricking the patient. So first we have to know the meter. Whatever device we are using, first we should be knowing that glucometer. We should be familiar with the device, what we are using. So the features may vary from sample size, waiting time for the glucose reading, alternate site testing capacity, communication with other devices like insulin pumps, continuous glucose monitors. So we have to know all these factors about a glucometer. So how to check the blood sugar? First, we have to gather our equipment. So what are the equipment? Lancet, test strips. So this is the lancet, these are the test strips, this is the glucometer. So first we have to gather the equipment, we have to wash the hands and dry thoroughly. And then we have to put on disposable gloves. First we have to turn the meter on, check the code if any code is present, then insert a strip. So we have inserted a strip into the meter and then hold the lancet device to the side of the finger and press the button to stick the finger. After this, we have to follow the instruction included with the meter when we are applying the blood to the strip. Usually, we should not smear the strip. We just have to drop it. So, and the blood should cover all the strip window. So here it is inadequately covered. Here we can see adequately covered. Sometimes the strip automatically wick the blood into the strip. We have just placed the edge. So automatically it will wick into the strip. We have to wait until the blood glucose results are displayed, and then we have to dispose the lancet and strip. So all the results should be recorded and documented. So we should know what does the display mean. So what are the values here? This is the battery indicating. So this value has not yet come. Here it is showing that we have to drop a blood drop. So here the units are different. This is 6.5 millimoles per liter. Here it is milligram per deciliter. HI means the value is showing very high. LO means the value is very low. So all these things we should know. What does the display mean? So if we have any doubts, go back to the manual and check the manual and see what the display means. So how frequently we have to measure? So whenever the patient is in a decay, diabetic ketoacidosis or hyperosmotic hyperglycemic state, or patient is on IV infusion for any reason, we have to check every hour or at least every 2 hours. If the patient is less sick or the patient is on subcutaneous insulin, then we can decrease the frequency. We can check for every 4 to 6 hours or usually before each meal. If there is any change in the condition of the patient, or we have started insulin infusion recently, or we have changed the nutritional regimen, or we have kept the patient in NBM, or we have changed it to TPN. Accordingly, we have to change the insulin regimen as well as the frequency of measurement. So what are the targets? So now we know the glucometer, how to measure and all, what are the values. So then now we have to know the glycemic target. So especially in the hospitalized patient. So what are the targets according to the American Diabetic Association? So the threshold for starting insulin is more than 180. So it is a red signal. You have to immediately start insulin. So what is the target glucose range? It is 140 to 180. In some patients where we are seeing a tight glycemic control, then the target can be 110 to 140. But most of the situations, the target is 140 to 180. And if the target is 110 to 140, we have to see that the patient who don't have any significant hyperglycemia because of the tight glucose control, he should not go into hypoglycemia. And depending on the terminally ill patients, severe comorbidities, and less nursing supervised, we can keep higher glucose range up to 200, but not beyond 200. According to the Research Society of Diabetes in India, the level of care, like glycemic target is in ICU, it is 140 to 180. In non-ICU, the fasting level should be 80 to 120, and the pre-meal value should be less than 140, and the post-meal value should be less than 180. So these are the glycemic targets. So what do you use? Usually we use insulin only in ICU. We don't go for oral hypoglycemic agents unless the patient is very, very stable. So what are the insulin types? First, we should know the insulin types. They are divided into rapid acting, short acting, intermediate acting, long acting, and combinations. That these are pre-mixed insulins. So what are the rapid acting insulins? These are analog insulins. Usually these are human recombinant insulins. Example are insulin Lispro, insulin aspart, insulin glulicin. So usually the onset of action is less than half an hour. Within half an hour, the onset of action will be there, and the action peaks almost 1 hour to 2 hours, and the effective duration is around 3 to 6 hours. So what is the short acting insulin? This is the regular soluble insulin. So here the onset of action will be usually 1 hour, 50 minutes to 1 hour. The peak action will usually around 2 to 3 hours, and the effective duration around 3 to 6 hours. So coming to the intermediate acting, that is NPH. NPH means neutral protamine hydron. Hydron is the person who have discovered this insulin, and the pH is usually around 7, which is neutral. So that's why it is called as neutral protamine hydron insulin. It is intermediate acting. The duration and onset of action is around 2 to 4 hours. Peak action is around 4 to 10 hours, and the duration is around 10 to 16 hours. Coming to the long acting, these are also analog insulins. So these are used for basal insulin, and the examples are insulin G-larginin. Usually this is the Lantus which we are using, insulin Detamil, and the other example is Tresiba, that is insulin Degludec. Usually there is no peak. The relatively flat line will be there. The duration, onset of action is around 2 hours, and the duration of action is 20 to 24 hours. In Tresiba, that is insulin Degludec, duration is more than 42 hours. The other combinations are like we are mixing the regular insulin as well as intermediate insulin in the proportion of 70 to 30%, 50 to 50%. So, or rapid acting insulin with intermediate acting insulin. So all these combinations can be used. So we can visualize some of the insulins. These are the rapid acting insulin. This is the glulicin analog. So here you can see the pre-filled pen. This is the cartridge, and this is the insulin syringe with needle. This is insulin syringe with needle used in the infusion pump. So next, Nova Rapid, that is the trade name for aspart analog. Here the onset is around 10 to 20 minutes. Various delivery systems we can see. It can be available as a cartridge used for infusion pump, vials, and pen. So these are the rapid acting. And coming to the other rapid acting or Lispro analog, and aspart analog is Fiasp. In Fiasp, the onset is only 4 minutes, and the duration is 3 to 5 hours. So it is available as a vial as well as a cartridge. Coming to the short acting insulins or Actrapid and Humulin S, that is a soluble human forms. So onset usually 30 minutes, 30 to 1 hour, and duration is around 10 to 12 hours. So this is available as vials as well as cartridge. Coming to the long acting. So as I said, G-larginin is the Lantus which we use generally, and the onset is around 1 hour, and the duration is around 24 hours. In whatever long-acting insulin, we have to give once daily at any time, but at the same time each day. So these are the various delivery systems. Coming to the Tresiba, here the duration is more than 42 hours because it is available in dihexamers, which are disintegrated into monomers and gradually enter into the system. So that because of that, the duration is very high, more than almost more than 1 day. So here you can see the pre-filled pen, 1 ml constitutes of 100 units, and another more concentrated version is there where 1 ml constitutes of 200 units. So what are the indications and use of IV insulin? So usually we use IV insulin in the following conditions like diabetic ketoacidosis, non-ketotic hyperosmolar state, critical care illness, whenever a surgical patient or medical patient critically ill, post-cardiac surgery, myocardial infarction or cardiogenic shock, NBM status, especially in type 1 diabetes patients who are dependent on insulin, post-labor or labor, during delivery, even antenatal state also we prefer to use insulin. Whenever glucose is exacerbated by high dose glucosteroid therapy, usually we are seeing this in COVID situations. So perioperative period, after organ transplant, TPN, total parenteral nutrition therapy. In all these conditions, we are using insulin intravenously. So concentration should be standardized throughout the hospital, and infusion controller adjustable in 0.1 units doses. Accurate bedside glucose monitoring should be done hourly, if stable. Every 4 to 6 hours can be done if you're using subcutaneous. So in all these situations, we have to monitor the potassium. Whenever we are giving insulin, so there is more chances of the patient going into hypokalemia. So we have to monitor the potassium whenever necessary. So what are the insulins which can be mixed in the same syringe? So NPH, which is an intermediate acting insulin, can be mixed with the rapid acting and short acting insulins and vice versa. But we should never mix insulins like long acting like G-larginine and detamir with other insulins. So coming to the injection site. So what are the injection sites? So usually the abdomen, upper arms, thigh region, lower back region and buttocks. All these are the injection sites. So whenever we are going to inject the insulin, we have to pull the skin by using the index finger and thumb. But we should not pull too much so that the muscular layer also gets included. We have to deposit the insulin in the fat, not in the muscle. What happens if we introduce the insulin into the muscle? Muscle has high vascularity. So it absorbs immediately and there are more chances of hypoglycemia. So we don't want that. So coming to the needles, time for injection, longer time of injection. So we have to place the syringe at least for 5 seconds. We have to hold the needle under the skin for at least 5 seconds in case of syringe, at least 10 seconds for the pen. It prevents leakage and it ensures the full dose received to the patient. And the needle should be shorter. The shorter the needle, the better efficacy of the drug delivery. So usually the 4 mm, 5 mm, 6 mm needles are used. We should not use 8 mm or 12 mm because it will increase the pain and there will be more risk of injecting the drug into the muscle. So it is not user friendly. So what is the angle of the needle inserted? That is usually 90 degrees angle. And we have to rotate the injection sites. So never we should give the same site, same day, daily, we should not use the same site. So what will it cause? It will cause lipohypertrophy. And here you can see the image where the patient has lipohypertrophy. So we should avoid this. So coming to adjusting the insulin dose. So whenever we are using a subcutaneous insulin, so if the glucose levels are out of target, so after breakfast, before lunch, the glucose is high, then we have to adjust the before breakfast rapid insulin or short insulin. If the post-lunch or pre-supper glucose values are high, we have to adjust the pre-lunch rapid or short insulin or morning NPH, which is an intermediate acting. If the mid-afternoon values are high, we have to adjust the morning intermediate or long-acting insulin analog. The post-supper or bedtime glucose is very high, we have to adjust the pre-supper rapid or short-acting insulin. If the early morning, that is around 3 a.m., if the blood glucose is very high, we have to adjust the evening intermediate acting or long-acting insulin analog. And what happens to the infusion? What are the adjusting dosages for the patient if the patient is on IV insulin infusion. For this, there are various insulin protocols like ALE protocol, Markowitz protocol, Levin protocol, Portland protocol, and many protocols. Here we are going to discuss ALE protocol. For example, here if the patient is on insulin infusion, for example, around 6 ml per hour, and the blood glucose is more than 200. And in the next 1 hour, the blood glucose suddenly dropped more than 100 mg per deciliter. So what we are going to do, we have to hold the insulin infusion for half an hour. And then after half an hour, we have to decrease the infusion by 2 times. That is, we have to decrease the units by 2 units. So we have to keep the infusion around 4. We have to decrease the infusion from 6 to 4. Accordingly, we have to change the insulin infusion by ALE protocol. So conversion of IV to subcutaneous. So first we have to note down whether the patient is eating or not. If eating, what he is eating or what she is eating, or when she is eating, how much they are eating. Any concomitant therapies are there, or is the patient on steroids? If the patient is on steroids, obviously the glucose will be high. If the patient is on inotropes or vasoconstrictors, we can't give subcutaneous insulin because the perfusion is less. And if the resolution of the illness or change in concomitant therapies reduces the insulin needs, all these factors we should take into account. And then consider the therapeutic options. So what are the therapeutic options we are having when we are converting from IV to subcutaneous insulin? So what should we do? Whether we should resume to the prior insulin regimens, or initiate the basal insulin, or initiate the basal bolus multiple drug injections, or initiation of the premixed insulin. So we have variety of options. So first, we have to continue the IV insulin until the patient is able to tolerate the solid food intake. And we have to continue IV insulin 2 hours after subcutaneous insulin injection is given. And we should not use basal insulin in patients whenever there is HbA1c more than 8.5% or on 2 or more oral agents. So we can use basal insulin, but we should not use only basal insulin. We have to combine it with another intermediate or rapid acting insulins. And don't switch to only oral agents from IV insulin in patients with type 2 diabetes. And arrange for an outpatient follow-up of the patients placed on insulin in the hospital. Definitely, we have to ask the patient for review, at least after 1 week, to adjust the doses. So first we have to establish the 24-hour insulin requirement. This is the basal bolus regimen. So what is the 24 hours insulin requirement for the patient? So extrapolate from average over last 4 to 8 hours if stable. So we have to give 50% amount as basal regimen, and accordingly we have to give the remaining 50% divided by 3, like 3 doses, each dose before each meal. And the correction boluses will be based on the carbohydrate intake. So for every 10 grams of carbohydrate intake, 1 unit of insulin should be given as corrected boluses. And monitoring should be done accordingly, and 3 times a day at bedtime, and usually at 3 a.m. in the morning. So how should we start the multiple drug injections? Before going to this example, we'll see the next slide. So what is the total daily dose? So if the patient is an underweight or older age patient or on hemodialysis, we have to consider the daily dose around 0.3 units per kg body weight. Normal weight means 0.4 units per kg body weight. Overweight, 0.5 units per kg body weight. If the patient is very obese, insulin resistant, glucocorticoids, it is usually around 0.6 units per kg body weight. So as I said, we have to divide the dose equally, and 50% should be given as basal and the other 50% should be given as bolus. So the bolus insulin is divided by 3 and given each dose before major meal. So what is the correction insulin protocol? This is a correction insulin protocol. Usually, if it is more than 140, the correction insulin is given. So if the patient is insulin resistant, we have to give more doses when compared to the patient insulin sensitive. So coming to the example here, so in a 100 kg person with moderate insulin resistance, we have started a dose around 0.5 into weight, that is 50 units. So basal dose is around 40 to 50%, usually 50%, that is 25 units we are giving at night. So remaining dose, that is 25 units divided by 3, so approximately it comes 8 units. So before each meal, we are giving 8 units. And given after meals as rapid acting analog if food intake is in doubt. So we should not skip the correction dose even if the food is eaten. So even if the food is not eating, even if the patient is NBM also, we have to give the correction dose and accordingly. So what all the correction dose given yesterday, total dose we have to take into consideration. 50% of the dose is divided into the basal and as well as bolus doses. So these are the protocols. So coming to the case presentation, so we have seen the patient, like 60 years old female, came with multiple episodes of vomiting. So she was tachypneic, she was tachycardic, she was having abdominal pain also. Here the blood glucose is 525, HB is 16, that is patient is dehydrated, the hematocrit is high, counts are elevated. So definitely she may be having infection. Infection in urine is showing plenty of pus cells, most likely urosepsis. So the infection has triggered the hyperglycemia and it has uh, led to ketones in the body. So lactates are high because of dehydration, hypovolemia. It entered into lactate acidotic state, and ketones, the metabolism changed it to fatty acids. So the ketones were increased. So anion gap is high. So the patient is having high anion gap metabolic acidosis. So coming to the differential diagnosis. So what are the hyperglycemic states? So if the blood glucose is high, so what are the conditions we should consider? The patient is having a diabetes in decay or hyperosmolar hyperglycemic state, impaired glucose tolerance or stress hyperglycemia as we have discussed, metabolic acidotic states, so lactic acidosis, only septic shock also leads to lactic acidosis, hyperchloremic acidosis. If you are giving normal saline in more amount, so it leads to hyperchloremic acidosis, uremic acidosis, drug-induced acidosis, as in salicylate poisoning, methanol poisoning, ethylene glycol poisoning. So the differential diagnosis for ketotic states, alcoholic ketosis, starvation ketosis, and ketotic hypoglycemia. So combinedly, hyperglycemia, acidosis, and ketosis is seen in DKA as is the patient. So next, we should differentiate what is the pathophysiology of this as we are discussing. So absolute or relative insulin deficiency causing hyperglycemia, which is causing osmotic diuresis, as we have discussed. So there is loss of water and electrolytes causing dehydration and hypovolemia. Perfusion has decreased. So aerobic has changed to anaerobic metabolism. So lactate was increased, and lactate is contributing to the acidosis. So the same dehydration and hypovolemia is increasing the counter-regulatory hormones like glucagon, cortisol, growth hormone, and epinephrine. So what is this doing? So adipose tissue, there is an increased lipolysis. In the muscle, there is a decrease in the glucose uptake, increase in the protein lysis, muscle lysis. And in the liver, what is happening? There is a switch over to the fatty acid metabolism. So here acetate is synthesized in terms of ketone antibodies like beta hydroxybutyrate and acetone. This is contributing to the ketosis part. This is also contributing to acidosis. Both lactate as well as ketones are contributing to the acidosis. So this is the pathophysiology. So what is the difference? What is the classification of the decay and HHS? So decay is divided into mild, moderate, and severe based on the glucose levels, arterial pH, and bicarbonate levels, and ketones, osmolality, and anion gap. So if mild decay is there, usually the glucose is more than 250 and anion gap is around 10 and bicarbonate is around 15 to 18. If the patient is in severe decay, the glucose is more than 250, arterial pH is less, so more acidic pH, osmolality is variable, but ketones are positive, actually more 3 plus. So anion gap is more than 12. In hyperosmolar hyperglycemic state, usually the glucose value will be very high, that is more than 600, and the volume deficit will also be very high, almost 8 liters to 10 liters. And the bicarbonate value would not be less as seen in decay. It is usually more than 15, but the osmolality value will be more than 320. So the osmolality is the differentiating factor here. So what we should do? So how are we going to manage this case? So first we have to replace the fluid loss. Whatever the water is lost due to osmotic diuresis, we have to replace it. So first we have to assume the volume deficit around 6 to 8 liters, and we have to replace the fluid, and we have to replace the electrolytes, and we have to restore the acid base balance. replace the deficient insulin, which is the main reason for all these situation, and monitor the blood glucose closely. And we have to replace energy losses. Whatever is the triggering factor here, the infection is the triggering factor, most probably urosepsis. We have to treat it, and we should avoid the recurrence. So what is the cause of urinary tract infection for her? Whether it is inadequate intake of water, or is there any bladder diverticula, or any reason for repeated infections, we have to avoid the recurrence. So coming to the initial and supportive management is mainly fluid therapy and insulin infusion. So fluid therapy, initially we have to give normal saline, almost 1 to 1.5 liter per hour. And after that, accordingly, till hypovolemia is corrected, we have to give around 50 to 200 per ml per hour. So what are the indications of admission to ICU? Hemodynamic instability or cardiogenic shock, altered mental status. Here the patient is in altered mental status. And respiratory insufficiency. She was tachypneic, severe acidosis. The patient was bicarb was almost 6 to 8, and hyperosmolar state with coma. All these are indications for admission to ICU. So first we have given NS, normal saline, and it should be given gradually, almost like 12 to 24 hours. Rapid correction usually results in cerebral edema, especially in children. So they are more prone for cerebral edema. So after giving initial 2 to 3 liters of normal saline, then the choice of fluid depends on the corrected serum sodium. If the corrected serum sodium is very high, instead of normal saline, we give half normal saline. And we usually prefer solutions with less chloride to avoid hyperchloremic acidosis. And we change to fluids containing dextrose once the RBS is less than 120 milligram per deciliter. So the fluid choice depends upon these conditions. So then insulin correction. So first we have to check the potassium. If the potassium is more than 3.3, we usually start insulin. If it is less than 3.3, we will simultaneously give potassium correction and we start insulin. We won't stop the insulin infusion for correction. What are the low dose regimens? So one is a continuous IV infusion. First here we are not giving any bolus. Directly we are starting 0.14 units per kg per hour. And another regimen is first we are giving a bolus dose of 0.1 units per kg, following a continuous infusion at a dose of 0.1 units per kg per hour. These protocols usually decrease the plasma glucose at the rate of 50 to 75 milligrams per deciliter per hour. So as I said, potassium adequately, first we have to adequately establish the renal function. Urine output should be around 50 ml per hour. If the value is less than 3.3, so usually we don't hold insulin, but we can hold at least for another 20 to 30 minutes and give immediately 20 to 30 millimoles of potassium. And then we have to start the insulin. If it is 3.3 to 5.3, we have to give the insulin simultaneously along with the correction. If it is more than 5.3, we should not give potassium correction. Instead, we have to check the potassium every second hourly. If there is phosphatemia, usually the correction usually given, the level is less than 1 milligram per deciliter. Monitor for hypocalcemia and hypomagnesemia. So we are treating the DKA with treating DKA. Means we are treating the dehydration by giving fluids. We are treating the potassium by giving restarting the potassium correction, or by correcting the anion gap. That is regular insulin is given until the anion gap is closed. And we are addressing the trigger factor. Here the trigger factor is infection. So coming to the hypoglycemia part. So not only hypoglycemia is very important. So what is the definition of the hypoglycemia? If the blood glucose is less than 70, it is considered as hypoglycemia. If there are neuroglycopenic symptoms like coma, seizures, then the condition is called a severe hypoglycemia. So what are the risk factors? Is there any delayed or missed meals, renal failure, liver failure, severe sepsis, adrenal insufficiency, quinolones, the patient is on beta blockers, endogenous causes like insulinema? All these are risk factors for hypoglycemia. So what are the factors which increase the hypoglycemic risk in inpatient settings? So as I said, decreased oral intake, renal failure, liver disease, beta blockers. Other causes are like lack of coordination between the dietary and nursing person, leading to mistiming of the insulin dose to the food, inadequate glucose monitoring, inadequate insulin dose adjustment, lack of coordination between transportation and nursing, unsafe work environment, transportation of ward causing meal delay, or new NBM status. The new NBM status is not known to the nutritionist, and the sister, without knowing of the interruption of the intravenous dextrose, TP, and enteral feedings, or continuous renal replacement therapy. All these have been interrupted, but in spite of that, she has given the usual dose of insulin. So obviously it will cause hypoglycemia. And use of sliding scale insulin in the absence of regularly scheduled insulin. So use of U for units. Like for example, we have written 20 units. So U is misinterpreted as 0 and the sister unknowingly given 200 units. So this will cause hypoglycemia. And similar names of the products. So manufacturer labeling disturbances. All this give the wrong dose to the patient. And non-standard compounded IV solution and infusion rates. All these cause increase the risk of hypoglycemia. What are the signs and symptoms? So symptoms are hunger, autonomic symptoms are hunger, sweating, anxiety, paresthesia, tingling sensation in the hands and foot, palpitations, tremors. Signs are pallor, tachycardia, wide pulse pressure. And neuroglycopenic symptoms like signs I have said, patient may go into seizure, coma, cortical blindness, hypothermia. And the symptoms are weak, fatigue, dizziness. First they initially start with a headache, leading to behavior changes, then confusion, cognitive dysfunction. Sometimes they have blurred vision, diplopia, finally ending into cortical blindness. So all these are signs and symptoms of hypoglycemia. What should we do? So if the patient is awake, we have to give orally with fluids containing glucose or sucrose. Or if the patient is drowsy, not able to take orally, or in critical situation, we have to administer IV 25% of glucose. So each ml of 25% glucose will raise the blood glucose by approximately 1 milligram per deciliter. So what are the future prospects? So now you are seeing inhaled insulin. So there is less chances of pricking. So directly they can inhale the insulin. So next, continuous glucose monitoring. Here the patient has a insulin pump. So accordingly, continuous glucose sensor will be there, which will be monitoring the glucose, and it will send an algorithm. According to that, insulin pump will be infusing insulin. So all these values will be entered into the mobile, and they can watch and see the values. What are the glucose values? How much insulin is going on? So continuously they can monitor. Accordingly, they can change the algorithm values also. So what are the core competencies of an ICU nurse? So bedside glucose monitoring technique, as we have mentioned. So what are the target blood glucose values? What are the critical? That is, what is the hypoglycemic value? So how we should administer insulin? What is the optimum timing of subcutaneous insulin slots? So hypoglycemia, what I have to do immediately? So what are the symptoms of the hypoglycemia? Whether the sister is able to recognize the symptoms or not? And what is the insulin dose given to the patient? And we have to document the blood sugar level and the insulin dose given to the patient. All this education, basic education, able to teach the nursing person survival skills. So what is the take home message? So stress hyperglycemia is common in the critically ill patients. Hyperglycemia and hypoglycemia both have adverse effects, so both should be monitored. And we have to minimize the wide variability in the blood sugars in ICU patients. And maintaining normal glycemia, that is the target value is 140 to 180 milligram per deciliter, improves the mortality, decreases the morbidity, decreases the organ failure incidence, and decreases the length of ICU stay, and even decreases the ventilation days. So you have to use the correct technique and correct glucometer and the technique of injecting the insulin. All this should be done correctly. And regular checking and appropriate adjustment of insulin dose as per protocols. You have to keep all the changes and all the interventions in mind, and we should avoid hypoglycemia at any cost. So this is the take home message, and thank you everyone. Madam, hand over to you, madam. Shall we ask some questions, ma'am?
Yeah, go ahead with the questions, Sowmya. Okay, any question? There are no questions on the chat box, which I can see from the nurses. Nurses, please, all the participants who are taking part in this presentation, please post your questions in the chat box so that we can ask Dr. Sowmya and then she'll be able to clarify your doubts. Are there any questions? Anybody wants to put it in the in the chat box, please do so that I can.
They're giving the answers, ma'am. So the question is, all are long-acting insulins except. So what is the answer? Whether it is digludec, dilarginine, aspart, or detimel. So what is the answer?
Okay. So most of them are saying C, most of them have listened to the talk, I think.
Yes,
So they're answering C. C is the correct answer. So as we all know, this is not short acting, it's a rapid acting insulin. Aspart is a rapid acting insulin. So diclofenac, glargine, and etomidate are the long acting insulins. So this is the correct answer. So shall we go on to the next
question?
Yeah.
So capillary tests not to be done in. So in which condition? Hypotension, hypoxia, jaundice, or all of the above?
Give them 1 minute time for the people to answer. I think we should have more participants answering. I am seeing only 1 or 2 people repeatedly answering. I think we need more people to answer. So again, all of them answering correctly. So the answer is D. So in all these conditions where the perfusion is less to the peripheries, or the patient hypoxia and jaundice, definitely a capillary testing by doing the skin prick test, skin prick and taking the blood sample is going to be false and is going to be inaccurate. Okay, so capillary tests using the skin prick and using glucometer, the point of care tests are not very reliable, especially if you use it, prick test and use the blood. If you use an arterial sample or a venous sample and use a glucometer, then it's okay. But if you're using a capillary test, then it's not a reliable test in the presence of above conditions. Go on to the next slide, next question, Sowmya.
All cause hyperglycemia except steroids, pancreatitis condition, beta blockers, hyperthyroidism.
Again, the answers are varying between C and D. Most of the answers are between C and D. C, D. So what's the answer, Sowmya?
Beta blockers, ma'am.
Yeah, so
Causes hypoglycemia.
Yeah. So it's very important for us to keep a list of the drugs which can cause both hyperglycemia and hypoglycemia. Both are equally important, especially antibiotics like quinolones. We give levofloxacin very frequently in a lot of patients in the ICUs or even OP basis. And we find that patients present with hypoglycemia. So you can prescribe hypoglycemia in a patient. So we're very careful with the drugs we're using. So beta blockers can also cause hypoglycemia. Whereas a lot of other conditions, other drugs like steroids, thiazide diuretics, okay, phenytoin, they all can cause hyperglycemia. Okay, then pancreatitis, of course, hypothyroidism, they all can cause hyperglycemia. So the answer in this question is C. So please take a look at the treatment chart and see what is causing hypoglycemia in a particular patient. So hypoglycemia usually caused by some drugs most of the time. So be very careful about the treatment chart and then follow the patient. Fourth question.
Rapid acting insulin should be given how much time, like how much time before the food? So whether it is 15 to 20 minutes, 30 to 40 minutes, 1 hour, or before 2 hours.
Again, most of them are answering A. Some of them, 1 or 2 people have said B also. So again, so Sowmya, which is the correct answer?
15 to 20 minutes, ma'am.
Yeah, so the answer is A. A answer is correct. So again, here we should all remember rapid acting and then we have short acting. But most of the time, the ICUs, as an infusion or as a subcutaneous dose in patients in the ICU, most often are using the regular insulin, which is a short acting insulin. So there, the duration of onset of action is around 30 minutes, 32 minutes to 1 hour. So we can give a food anywhere between 30 to 40 minutes after giving insulin. We can give a food at 20 to 30 minutes. You can give the food. Whereas in rapid acting insulin, the onset of action starts within 20 minutes to 30 minutes, and it peaks at around 1 hour. So we need to give food within 15 to 20 minutes after we give a rapid acting insulin. So the rapid acting insulins include Lispro, Aspart. These are 2 common rapid acting insulin which are available. But most often in the ICUs, what we use are the regular insulin or the human act rapid insulin, which we use commonly, which usually should be given around 20 minutes to 30 minutes before food. Yeah, 15 to 20 minutes or 30 minutes before food. Whereas rapid acting should be given much
earlier.
The meal, yeah, closer to the meal. Okay, next question.
Whenever the patient is on insulin infusion, so how frequently we have to monitor the blood sugars? So every 1 to 2 hours, or 4 to 6 hours, or every 5 minutes, or every 90 minutes. So what is the frequency of monitoring?
So most of them are answering correctly here. is 1 to 2 hours. So like Sowmya already presented in the previous presentation, IV insulin infusion is predominantly used for patients who have diabetic ketoacidosis or who are in, especially the patients also has sepsis, critically ill and has been shock on vasopressors. Again, their subcutaneous insulin is not going to be helpful for us, even though the sugar is not very high. Even with borderline sugars without DKA also, we have to go for IV insulin because subcutaneous insulin will not be reliable and we may cause hypo or hyperglycemia because we cannot control the absorption of the sugar from the subcutaneous space into the circulation when the patient is having hypotension or is on vasopressors. So patient critically ill, has shock, is on vasopressors, or patient is in DK because it's not much better control, or patient is having hyperosmolar state, HHS, and all these conditions, or where we don't know whether the patient is going to eat or not going to eat. Okay, patient is vomiting, intake is not guaranteed. There also, if it's also infusion, we can always stop the infusion if the patient develops hypoglycemia. So it's always better to, in such situations, go for an IV infusion. So once your patient is on an IV infusion, if the patient is having decay or even HHS or otherwise, we don't want a very rapid fall in sugar also. So for that reason, it's always, and we want to prevent hypoglycemia also, and also want to control the blood sugar well. So for all these reasons, we need to monitor at least 1 to 2 hourly so that we can take good control of the blood sugars and adjust the insulin infusion rate. So the answer is A for this. Next question. Once the patient starts eating and then we go on to subcutaneous dose, then we can switch over to either 4 times a day, like before each meal. And if required, again, we can do it in the midnight or at 3 a.m. in case the patient is having any features of hypoglycemia or hyperglycemia in that time. So otherwise, when the patient is infusion, we have to check every at least 1 to 2nd hourly.
So next question is, what are the sites of administration of insulin? So where we have to administer? All except. So options are abdomen, thigh, buttocks, forearm. So what is the exception to the protein sites of administration?
Some people are saying D, some are saying D. So most of the answers are coming as C, D. Majority are C. D, some are saying D, C and D is between a fight between the C and D. Some are saying D also. I don't know why somebody is saying D. Commonly given the abdomen and thigh. So there's no doubt about those
Doubt about that.
Yeah. So Sowmya, what is the answer for this?
Answer is forearm. We usually give in the buttocks and back of back area also, buttocks, back region of the thigh, abdomen, even upper arms.
Upper arm can be given, but not the
But
forearm.
never in the forearm.
Yeah, because there's not much subcutaneous tissue there in this forearm for you to give the insulin. Okay, so we have to most often we give it in the abdominal wall or in the thighs. This is most of them. But if you have to, if you're getting frequent doses, we can probably use other areas also, like the buttocks and upper arm. We can keep it as a last resort, but most often thighs and the abdomen. If you have, like she said already, if you give it in the same place frequently, you'll get what is called lipodystrophy. Lipodystrophy. So because of that, we can avoid that by using multiple sites at different points of time.
Rotation of the sites.
Yeah, rotation of the sites. Okay, go on to the next. And very important when you're giving to avoid hypoglycemia, please make sure you see the how many units are there per ml, because there are some companies provide 100 units per ml, some provide 40 units per ml. Nowadays, in the Western countries, 40 units per ml is usually not available. In India, some companies still do provide 40 units per ml. So we need to be sure how much you're taking. So if you're using a 40 units per ml vial of insulin, you have to use a corresponding syringe. The syringes also are different. So the 40 units per ml syringes are different versus the 100 units are different. That's very, very important, because a lot of times this mistake has happened in the nursing level or even doctors level also has happened, where they have taken a 100 units per ml syringe, or they've taken a 40 units per ml per syringe for a 100 units per ml insulin. Then what happens? You tend to take a much higher dose of insulin for the same this thing. So that way you'll be giving a patient a higher dose than what the patient actually should be getting. Then the patient has a high chance of going into hypoglycemia. So please make sure when you're taking the insulin syringe and loading it on, if you're using a pen, it's okay. Then it's very clearly there, the units you can rotate and then you can give the pen properly. But if you're using an insulin syringe, loading it and then giving it subcutaneously to the patient, always have to, the same to match. The insulin vial also has to contain 100 units per ml. The insulin syringe also has to be the 100 units per ml with the markings, appropriate markings. Then only you'll be giving the correct dose to the patient. So please be very careful about this before giving the insulin. And the storage of insulin is very important also. You have to keep it in the fridge. So it should not be lying outside, because it can always get damaged. So insulin also has to be kept in the fridge. So please be very careful of, before giving the patient the dose of the insulin, check the dose properly, what the doctor has advised. Then second thing is check the insulin, what you're going to give, the syringe, appropriate syringe has to be taken. third important thing is load it properly. And then the technique of the administration also very, very important. Site of administration, technique of administration very important. All these can prevent both hyperglycemia and hypoglycemia to the patient and prevent any dangerous side effects of their insulin. Okay.
So next question, ma'am. Glycemic target in ICU. What is the range of glycemic target?
Yeah, so most of them are saying B.
140.
The talk at least the type, because it's very important. So we need to know what is the correct level we need to maintain the patient, the sugars in the ICU. So anybody who has more than 140, we definitely have to make sure we correct the hyperglycemia. And we can maintain it around 140 to 180 blood sugars. We can try to maintain that range. The patients who are diabetic or who have hyperglycemia in the ICU. So that's the right answer. So they have found that if you try to maintain a very strict control and try to maintain between 80 to 120, you have a higher chance of having a hypoglycemia sometime or other. So therefore, the episodes of hypoglycemia much more if you're very strict in your control, you try to maintain between 80 to 110 or 80 to 120. They found that the chance of the patient having hypoglycemia were more because of so many factors. Like patient does not eat sometimes suddenly, or patient is NBM, or patient is some other intervention, he goes for CT scan and is NBM, or he comes and there's a delay in him getting the food, some reason or other, and even the tight control, and you monitor only 4 or 5 times a day. So all these reasons, the patients they have found that they tend to have a higher chance of developing hypoglycemia. So they said absolute range is 140 to 180. So as long as the patient sugars are between 140 to 180, the damage of hypoglycemia will not be there. And at the same time, the effects of adverse effects of hypoglycemia also will not be there. So you can improve the quality of outcome of the patients in the ICU. Next question.
All can be given as a basal insulin, except.
Most of them are saying C, but some are saying B also. B, C, most of them are C. So what's the answer, Sowmya, for this?
Aspart, it is a rapid
so
action.
Answer is C. Yeah, answer is
Should
C.
not use it as a basal insulin.
Yeah.
So
long
acting.
So I'm sure all of you understood by now what is basal insulin, what is bolus insulin.
Bolus insulin.
Once the patient is off insulin infusion, so we know that now the patient recovered to a stage where he can tolerate subcutaneous insulin. That stage, we have to divide our insulin into 2 components. One is the basal insulin, that is a long-acting insulin or an intermediate-acting insulin. If you give intermediate-acting insulin, you give it twice a day. If you're giving a long-acting insulin, you give it for once a day. So this insulin, long-acting, will cover the 24 hours. Insulin requirement will cover. At the same time, you have to also give a bolus insulin, which is going to be a short-acting or a rapid-acting insulin to mainly cover the food that the patient is taking. So each time when he eats morning, afternoon, night, the sugars are going to increase after his meal. So to cover that meal and to prevent that hyperglycemia immediately post-meal, to prevent that, you have to give a bolus dose of insulin, and bolus doses are usually given with short-acting or rapid-acting insulins. Whereas basal doses, that is you give an intermediate-acting or a long-acting. If you give intermediate-acting like NPH or what we call insultard in some of our companies, in Indian companies, there you give twice a day. If you're giving a long-acting like Glargine or Lantus or that kind of thing, you give it only once a day. So that you have to give a combination of both. And that way you can adjust either the short-acting or the long-acting or both to maintain the 24-hour sugars in the range of 140 to 180. So that will be your should be a target. And they should use a combination of basal, and you should not give only bolus or you should not give only basal. If you give only basal insulin only twice a day intermediate-acting, then all the post-lunch sugars, post-breakfast sugars are all going to be very high. If you give only bolus insulins and you don't give a basal insulin, then only your immediate post-breakfast sugars will be controlled. But again, like just before lunch or just before dinner, those sugars are going to be high, or midnight sugars, they all are going to be high. So to prevent hyperglycemia during the entire 24 hours, you have to give a combination of basal and bolus insulins. That's very, very important. And you adjust it like based upon the sugars before breakfast, before lunch, and before dinner sugars. You adjust which dose should be increased and whether short-acting should be increased or long-acting should be increased, and accordingly you can this thing. Okay, so the answer here is only short-acting one is aspirat, so that's why that's the right answer. Any more questions, Sowmya?
No, ma'am. End of the only 8 questions I have framed.
Okay, there's one question. I think this is from Saji. So he has one doubt. He's saying, how does one decide on the dose of, Sowmya, this questions to you. How does one decide on the dose of short or rapidly acting insulin pre-meal? Because we're not sure how much one eats, how much of what one eats. And when when do we check if it was right in a ward patient? Or it's trial and error. How to do by trial and error method? Or do we know how much to give? So when do you check next? Say if you given a dose before the breakfast or before lunch, and then when do you check the sugar again to know whether you're giving the right dose, or whether it's high, low for the patient or high for the patient, or how do you decide?
Usually, 2 hours after lunch or after breakfast, we again check it, ma'am, whether the dose is correct or not. And before that also we can estimate based on the carbohydrate meal. So for every 10 grams meal, we use 1 unit. So we have a rough estimation. So how much carbohydrate the patient is going to take.
And the previous, you can see the
yes, previous 24 hours requirement also.
Yeah, every day when you're advising the sugars for the particular patient before breakfast today, you see the previous days before breakfast, what was the sugar? What was the sugar? How much was the patient eating? What did he eat? And what insulin did he give before? How much insulin did he give before that? And then what was the pre-lunch blood sugar? So based on that, you can adjust the today's dose of insulin. And like they said, rapid acting, you can always give immediately after the patient eats also. Because rapid acting will only start within 20 minutes. By the time the patient absorbs the food, the rapid acting will start. So you can sometimes the patient, you're not sure of the patient intake, you can use rapid acting instead of a short acting, because that way that the chance of hypoglycemia will be lesser. Because if the patient is not eating, then you can decrease the dose of rapid acting. Whereas short acting, if you give off before the meals, then you will likely to have hypoglycemia if the patient does not eat. So better to use a rapid, in such a situation where the patient's intake is variable, you can go for a rapid acting insulin just immediately after the patient eats. Based upon how much the patient eats, you can give it immediately.
So before 24 hours, what are the correction doses we can accumulate it, ma'am? So for 24 hours, what are the correction doses we have given in the last 24 hours? So we can accumulate the total dose and we can divide the same dose into the basal and as well as bolus. Yeah, so to correct the next next 24 hours, you can correct the sugar insulin. Another question to you, Sowmya. One is, how do you give a fluid therapy in hyperglycemia? Patient is CKD or the patient is LVF? So we do the fluid monitoring, like a hemodynamic monitoring. We will check, we will see the fluid challenge. First, we give fluid. Accordingly, we will monitor the urine output and we see the IVC status. If possible, we attach a cardiac monitoring. So according to the necessity, we will give the fluid, but we will never stop the fluid, even if the patient is CKD or having any dysfunction like a heart dysfunction.
No, even if the patient has LV dysfunction or has CKD, we need to monitor. We have an ultrasound with us most of the time. So we can see that LVF, yeah, whether the patient is going to get up in B lines or starting to have hypoxia, we can always stop the fluid. So second thing is the patient has CKD. Definitely we cannot give a lot of fluid like we can give in other non-CKD patients, but we can give a smaller amount with close monitoring. In both CKD and in LVF patients, we definitely have to do a very close monitoring. And whenever we think that the patient is going into fluid overload or starting to develop fluid overload, we have to stop the fluids. Then only insulin that has to be corrected. And then if required, we have to like go for a, even may have to go into, if the patient does go into fluid overload and goes into LVF again because of our fluids, whatever given or other conditions also, then we definitely have to give dialysis. There's no option there, because then that, but we have to control the, till possible, how much we can give with close monitoring, we can give the minimal fluid the patient can tolerate. Yeah. Okay, any more questions? I don't see any more questions. Some of them, how much time does it, yeah, one more question is, how much time does it take to correct ketosis if no cause is seen?
No cause is seen. We don't know how much time it will take, but usually it takes at least 24 to 48 hours, depending on the severity. So we will be checking the ABG, we will see the anion gap, whether it is closed or not. We will check the ketones also, whether it has become negative or not.
Yeah, ketones is usually not very relevant.
Relevant terms.
Yeah. So most importantly, you need to follow the anion gap.
Anion gap.
For treatment of DKA. Anion gap. So once the anion gap is corrected, then okay, you're corrected the ketosis. Ketones may remain positive for some more time because ketones, the excretion will continue. So you don't have to worry about the serum urine ketones so much. Ketones is mainly used for diagnosis. So once you treat the patient, you don't have to follow the ketones very regular intervals or anything. And more than the ketone levels, it's more about the anion gap and the acidosis that needs to be corrected before you say that the ketosis is improved. Okay. So usually most often, even severe ketosis, we are able to close the anion gap in, like she said, in 24 to 48 hours. So by 48 hours, we should be able to, and we should be, if you're doing a good job, that means you will correct the ketosis in 48 hours. and the patient usually you're able to start orally and then switch over to subcutaneous insulin. So once the iron gap closes, you can switch over to subcutaneous insulin. The patient is taking orally, conscious and taking orally, and no vomitings and all that, you can do that. I think there are no more questions. I think,
Yes.
any more questions? No, I don't see anything more in this thing. So I think we'll end this session. So what I want to, okay, there's one last question just come. For diagnosis of DK, which is ideal, either serum ketones or urine ketones? Definitely serum ketones is picked up much earlier, and it's more sensitive for diagnosis of.
But it will take time for a diagnosis. So readily available is urine ketones by strip method. So usually bedside we can do it. So we prefer that.
And usually it's not available. Most of the time, serum ketones are tests are not available freely in the labs, most of the hospitals also. So it's all much easier to diagnose by using the urine
ketones
test.
And
ketones give false result as the DK improves. Yeah, definitely even if DK improves also, ketones may still remain positive, like I told you, for some time. So don't bother about the ketones once you have started treating the ketoacidosis. Then the urine ketones have no value. So just there, only iron gap is the most important thing. Blood sugars and the iron gap. And the patient's overall condition, the patient's going clinically. Okay. So we'll stop the session. Very, very important thing is avoid hypo and hyperglycemia, and please avoid wide variation in the blood sugar. So that was been shown to have an increased mortality. So one day morning sugar is 90, second day again by night the sugar is 300, 400. Next day morning again it is 75. Again night it's around 400, 500. So that wide variability on a day-to-day basis or even on a single day is more dangerous than having sugars in the same range of 180, 200 or 210 or 250. So that wide variability also is supposed to be harmful to the patients. So we all should monitor the patients better and then take care of their sugars. So
and before closing the session, madam, this slide I think you're able to see. This is the Banting and West who have discovered the insulin.
Okay.
So that's why I kept the thank you slide.
Well, I thank you, Sowmya, for a
yes, thank you very much.
And very good questions also. And I think a lot of them participated also in the question answer session. And I thank ICCM nursing for giving me this opportunity to moderate this session.
Yes, ma'am.
Thank you, everyone.